Welcome, everybody. As the president of World Stroke Organization, the convener of the Global Stroke Action Coalition, today marks the first public event of the Global Stroke Action Coalition, the world's first global multi-sector advocacy movement dedicated to addressing the stroke crisis. The speakers today will outline the impacts that stroke has on individuals, societies, and economies, and the projected impact that stroke will have if we do not act now. The coalition's goal is to make sure that stroke gets the recognition, prioritization, and funding needed to shift the course. World leaders will gather at the UN high-level meeting on non-communicable diseases in the month of September this year, where they will shape the global NCD strategy for the next 25 years. This is a crucial moment for us to ensure stroke is not overlooked in the global agenda. Today, the coalition is also unveiling a policy brief which includes 5 clear and actionable asks for governments and health stakeholders to address the stroke burden. By seizing this moment and making stroke prevention, treatment, and rehabilitation a priority, governments have a powerful opportunity to improve the lives of millions and accelerate progress towards both national and global health goals. Now I hand over the session to our esteemed moderator, Sharon Epperson, Senior Correspondent, CNBC.
Thank you, Dr. Pandian. Thank you all for being here today. It is my pleasure to moderate this very important inaugural event for the Global Stroke Action Coalition. I thank the American Stroke Association and the World Stroke Organization for inviting me to moderate this discussion. And I am a senior personal finance correspondent at CNBC. I am also a stroke survivor. In September of 2016, I felt the worst headache of my life. I had never experienced anything like it, and I was actually working out in a core bar studio, trying to do the right thing, eating spinach, taking care of my health, and trying to prioritize exercise. But it was that downward dog position where I felt the worst sensation in my head and immediately asked my husband to pick me up from the studio. We went home, I put my feet up. I should have gone to the emergency department at the local hospital, but I did get there eventually after seeing a primary care physician. And then I went to a local hospital to have imaging done where they found through a CT scan bleeding on my brain. I then had to go to an academic medical center that was near this local hospital because they didn't have the facility to take care of me. And that center, Montefiore Hospital in the Bronx, New York, saved my life. I had a craniotomy. I have 2 clips in my brain that stopped the ruptured brain aneurysm that nearly took my life. I was in the hospital for a month, 2 weeks in intensive care, a few days in the regular unit, and then 2 weeks in inpatient in a rehab hospital. But I was away from my position as an on-air television correspondent for 12 months. And during that time, my job was rehabilitation, occupational therapy, speech therapy, physical therapy to try to resume my life on television, but also as the mother of 2 children who were at that time in their teenage years. In subsequent years, I have learned that the hemorrhagic stroke, the brain hemorrhage that took the life of my aunt, of my grandfather, and my great-grandfather means that I have a family history likely of brain aneurysms. I have a stroke history. And that's very important to know and to make sure that my family members, my children, and my cousins and family members are screened properly and understand what they can do if there are any type of warning signs. What I've also learned is banding together can really help to progress the recovery process, going to support groups, finding organizations like the American Stroke Association, like the Brain Aneurysm Foundation here in the US and internationally. That has definitely helped me in terms of regaining my confidence, actually, to come back to the world as a new person who is a stroke survivor. 1 in 4 people will suffer a stroke in their lifetimes. Today, there was a policy brief that has been launched about stroke prevention from the Global Stroke Organization. And I think it's very important that we understand that we have the power we all have the power to change those statistics. And today you're going to hear from stroke survivors, you're going to hear from neurosurgeons, you're going to hear from scientists, researchers, as well as people who are working on the ground to make change happen, from the NCD Alliance, from OECD, from the World Health Organization. And I am delighted to be a part of moderating this discussion and hope that you understand this is for you as well. There is a Q&A section there on this panel, and so you can ask your questions of the panelists as well, and I urge you to do that. Before we begin, though, I think it's important, you've heard a bit about my story and my interest in being an advocate and part of what is happening here. I'm also part of what's happening in Washington, D.C., and advocating there for more funding for brain aneurysm research and stroke awareness. There are many people doing that all over the world. And one that you're going to hear from now is from Rwanda. Joseph's story is very compelling, and take a listen now.
My name is Joseph Rukelibuga. I am a Rwandan. I have lived the experience of diabetes, hypertension, and stroke. I was 57 when I had my stroke. I am the founder of Stroke Action in Rwanda, and as such, an advocate of stroke survivors. I have been working for the US CDC as avian influenza specialist for 11 years. I went to retirement in 2019. My experience about stroke acute treatment is unique. My stroke occurred at home on 20 June 2016 at 4 a.m. in the morning. Within 1 hour of symptom onset, my wife managed to bring me to the nearest referral hospital, where a general practitioner gave me an intravenous drip to reduce my blood sugar and blood pressure that were alarmingly high. I was then admitted to the general ward to wait for a specialist doctor who was on night duty at another referral hospital. He arrived almost at 9 a.m. and after examining my case, recommended an MRI exam, which unfortunately turned out inconclusive. Confirmation of ischemic stroke with left side hemiplegia was obtained the next day using carotid artery ultrasonography. The physician prescribed cardioaspirin and advised continuing diabetes and hypertension medicines, which restored rapidly my vital signs. I was discharged to home after 6 days in a wheelchair. After hospital discharge, physiotherapy and talking with other stroke survivors is what got me through. From my lived experience, it is important for all countries to have national stroke action plans. Indeed, on one hand, the impact of stroke on patients, families, and society is devastating, while on the other hand, in many countries, stroke care services remain virtually inexistent. It is like countries are massively off track of prevention of stroke, the second leading cause of death and disability worldwide. In the lead up to the fourth UN high-level meeting on NCDs and promotion of mental health and well-being that will take place in September 2025, it is time to seize this opportunity to call upon countries to fulfill their commitment to tackle the burden of stroke by developing and implementing national strategic plan.
Thank you, Joseph. We appreciate your story and your honesty in telling it. And I think it's important to recognize, I am recognizing really for the first time, Dr. Pandian, that as a stroke survivor, I felt so alone in my journey, even though I've talked about support groups that I've attended in New York City and places around the US. But to know that we have people from Finland, UK, India, Spain, Italy, South Africa, Canada, Switzerland, Tanzania, Poland, Ethiopia, the US, and so many other places around the globe on this call right now is tremendous. You all know that every minute a stroke is untreated, 1.9 million brain cells die. Every moment counts. Fast access to medical treatment is critical. And as the policy brief outlined by the Global Stroke Action Coalition has said today, it is so important for all of us to gather together to help change lives and change the statistics. Sheila Martins is co-chair of the Global Stroke Action Coalition. She's a professor as well, and also the past president of the WSO. And Sheila, I will turn it over to you.
Thank you. It's a great pleasure to be here in this launch of Global Stroke Action Coalition and why we are talking about stroke and why now. Stroke is the second cause of death in the world, one of the main causes of disability. 12 million new strokes occur every year, 7 million deaths every year, and 94 million people living with effects of stroke in the world. 1 in 4 of us will have a stroke in our lifetime, and 89% of these strokes with disability and mortality will occur in low and middle income countries. And stroke don't just affect older people. 1.8 million people will experience a stroke before 50 years old. And besides the personal and social cost of a stroke that affects not only the patient, but also their families, the economic cost is also immense. So every year we spend $900 billion due to strokes, 300 billion healthcare costs, and 570 billion loss of productivity. If you do not act now, by 2050, the picture will be worse. From 7 million deaths per year, we will have 10 million. From 140 million disability adjusted life years lost, we will have 190 million. And from 900 billion costs, we will have 1.6 trillion. So really, we need to act now, and we have the power to change this. The stroke care changed dramatically in the last 30 years, and the implementation of evidence-based prevention and care can change the natural history of stroke and save millions of lives. Many strokes can be prevented. And prevention is the most effective and cost-effective way to reduce the burden of stroke. For each dollar spent on preventing stroke and heart disease, the return is over $10, achieving 50% population blood pressure control by 2050 alone could generate economic benefits of up 5.3 trillion, while preventing 120 million strokes and 76 million cardiovascular deaths. So we have a lot to do with simple actions. You can change this reality. 80% of strokes can be prevented if you act in 10 modifiable risk factors. So Hypertension is the most important, and controlling hypertension can decrease half of cases of stroke, but also smoking, high cholesterol, air pollution, south diet, diabetes, unhealthy diet, alcohol abuse, obesity, atrial fibrillation. Unfortunately, the risk factors are not identified. When identified, they are not treated, and when treated, they do not achieve the goals that could decrease the chance of a stroke occur. So if you, in hypertension, that is the most important example for us. In the world, the WHO evaluation, 46% of people with hypertension are not diagnosed. Of those, 58% are not treated, and only 21% of people with hypertension have their blood pressure under control. So we need to act on this now. But if strokes occur, stroke has treatment. A revolution of stroke care in the last 30 years has changed the lives of patients. So now, three main interventions: a stroke unit, a dedicated area with a multidisciplinary teams and protocols for all stroke patients can decrease mortality and disability. Thrombolysis, a medication in the venous system, can dissolve the clots that occlude the brain arteries, recovering the brain circulation, decreasing disability. In mechanical thrombectomy, a brain catheterism with a clot removal through a stent or aspiration is a powerful treatment for more severe stroke, one of the most powerful treatments in medicine, and should be used. These treatments can dramatically improve patient neurological outcomes, minimizing disability and reducing the social and economic impact of stroke. 5 wins for effective stroke treatment: improve patient outcomes, reduce risk of disability and dependence, alleviates the burden of families and carriers, increase productivity, and reduce the strain of wider health services. And all of them are cost effective, but unfortunately, a lot of services a lot of these treatments are not implemented in some countries. Any treatment, any hospital has possibility to give this treatment for the patient. So we need to really have this treatment in everywhere to everyone. In rehabilitation, improves long-term recovery. 2 in 3 stroke survivors experience long-term disability. Start early rehabilitation between 24 to 48 hours can reduce disability and help people to have independence, self-sufficiency, create opportunity for people return to the workforce, enable people to actively contribute to communities and societies, and reduce the burden of caregivers and national health systems. So really, we need to act now. Telemedicine can help to include these treatments in areas without a specialist. A strong educational program is so important to educate health professionals in hospitals, pre-hospital, and also in primary care units. And stroke awareness campaigns are fundamental, including in schools. Stroke center certification can ensure that everything that is evidence-based is implemented and worldwide is improving the quality of services. And we have concrete examples. For example, implementation of stroke services in Ethiopia, acute stroke services as a model for low-income countries, organizing stroke units, training for all people, organizing stroke teams, donation of medication, TPA out the place to start intravenous thrombolysis, data collection, and what they show that is feasible to implement in these hospitals, and mainly that increase organization, improve the quality for all stroke patients, and with this decrease mortality. In Tanzania, the same, working together with the Minister of Health, then implemented stroke units, organize stroke teams, educate the teams, collect data from all hospitals, now increasing the number of hospitals with the treatment and starting intravenous thrombolysis for the first time in the country. We have a good example in Brazil with a complete line of care organizing prevention with free medication for risk factors, hypertension, diabetes, dyslipidemia, and atrial fibrillation, national monitoring of risk factors, self-reduction in industry products, strong public pre-hospital organization. Since 2012, thrombolysis and stroke units supported by the government, 2023, mechanical thrombectomy, 2024, National Stroke Day together with the World Stroke Day, with the strong educational program, telemedicine, certification of services, and strong support for research in stroke sponsored by the government to translate this in public policies. We have several other countries and regions with stroke national plans that is fundamental, including in Europe that has a robust, through European Stroke Organization, strong government program in Canada, a strong monitoring program in United States, together with American Heart, American Stroke, and certification program improving the quality. So 5 urgent actions to reduce the burden of stroke. The final message: make stroke a priority, part of non-communicable disease health strategies, develop national stroke action plans, commit to funding stroke action now, implement robust stroke monitoring system, and include stroke survivors and caregivers in policy development, because we are here for them. Thank you so much.
Thank you so much, Sheila. Thank you very, very much. We are here for all of us to be together. And again, we're seeing even more people coming from Brazil, as well as Argentina, Romania, Colombia, Germany, Guatemala, Nigeria. Thank you all for being here, and thank you for introducing yourselves on the chat. Sheila, it is, as you're saying, talking about, I'm taking notes on everything that you're talking about. And I think it's so important to recognize what having a comprehensive stroke center can mean for a community. One of the community where I was, the hospital that I was in the Bronx, New York, is seen as an economically depressed community, yet the hospital system is one of the top 1% of neurosurgery and neurology in the nation, in the US. The rehab hospital in the top 1% of the nation in the US. But these are recent designations, where being an advanced comprehensive stroke center. This has happened since 2016 when I had my hemorrhagic stroke. So progress is being made, and we need to acknowledge that and find the best practices from Brazil, from New York, from Germany, all over the world, to make sure that we have the best practices in place. And one way, I think, Sheila, to talk about that as well is to find out what the World Health Organization is doing, what the World Health Organization is doing globally and regionally. And we have Dr. Hussain Rasheed here with us today to talk a little bit about that. And I'm glad to be able to speak with him and to ask him a few questions. Thank you for joining us as well, Dr. Rasheed. As you can see there, all of his distinctions and his work, not only with the World Health Organization, but also what he is doing as a researcher, an academic, and an advocate for stroke prevention. If I can't see you, but I think you're there. Doctor, you are there. Yay.
Yes,
thank you for raising your hand. So I'm gonna ask you a few questions, and I want to let everyone again know in the chat, some of you, in addition to introducing yourselves, have shared some comments, but please pose your questions as well, so that we can make sure that we are answering what you want to hear. But a few of the things that I want to know about, can you just give us a bit of an overview of the World Health Organization's work in Southeast Asia, and particularly in addressing the stroke burden?
Thank you, Sharon, and good morning, good afternoon, good evening from wherever you're joining this session. At the outset, heartiest congratulations to World Stroke Organization for creating this much needed collaborative and multi-sectoral initiative focused on Global Stroke Action Coalition. And coming to the question, I think this is very relevant in the context of the WHO Southeast Asia region, which is comprising of 11 countries and is home to over 2.1 billion people, approximately a quarter of the global population. So if we look at the overview in terms of the region, the annual incidence of stroke in the region is about 1.3 million new cases as per the global burden of disease data. And there is a significant variation in stroke incidence across countries. There's so much variance we can see. And Indonesia has the highest age standardized incidence rate in our region. In keeping with the global pattern, stroke incidence is higher among males compared to females in the region. And in terms of mortality, the WHO Global Health estimates in 2021 showed that stroke is the second leading cause of mortality in the region. Now, stroke causes around, as I mentioned earlier, 1.5 million deaths annually, which is about 40% of global stroke-related deaths. Most of these deaths occur in the productive age group of 30 to 70 years of age, causing severe economic losses and, of course, impacting quality of life as well as dailies. So I'll stop over here just to give, in terms of where we are on the burden of stroke.
Yeah, looking at stroke prevention in terms of treatment and care as well, what are some of the most important actions, the most urgent actions that you believe need to be taken right now?
I think first of all, if we look at in terms of the responses and urgent actions, of course, if we look at the suboptimal level, national response remains the biggest gap in stroke prevention and management across the region. Now, commitment and resources to implement evidence-based, cost-effective interventions to reduce behavioral and metabolic risk factors need to be strengthened at the population level. And of course, priority should be given to the implementing WHO's technical package, whether it is the Empower, the Safer, the Active, Shake, Replace, and Chest. These are some of the identified best buys. I think it is time that we accelerate implementing those available technical tools. And of course, if we look, there is large unmet needs in addressing hypertension and diabetes, and it requires stronger primary health care interventions to tackle the gaps in awareness detection, treatment and control, and of course, through strengthening health systems. So I think we need to strengthen our work in increasing awareness and, of course, increase the capacity of health professionals as well, and to address poor referral linkages in most of the countries. And I think these are areas that needs to be addressed as an urgent thing.
Absolutely, absolutely. There is a question from the audience, from one member who asked, does the World Health Organization include stroke survivors on teams, or at least recommend doing so?
We do have some staff who are already part of the workforce, who are actually supporting implementing of the program. So we already have mechanisms of supporting the system itself. So I think we are providing that platform within WHO itself.
Excellent. And are there developments you are most excited about to offer hope to stroke survivors? Any new medicines, any new treatments?
Of course, it's an ongoing process, and in terms of the work that we are doing at the regional level, I think certainly strengthening stroke care and surveillance across countries is a huge priority for WHO. And the region, particularly in Southeast Asia region, we have designated some of the establish centers in the region. For example, we have Christian Medical College, Jeyaraj is here, is in India as one of the world's first WHO collaborating center for stroke, aimed at offering technical backstopping and research-based evidence to improve stroke care services. And of course, with the support of the Collaborating Center, stroke care appraisals have been conducted in a lot of countries to identify gaps and support action plan development. And I think this is very important. And countries have also, with WHO's support, received on-site support to establish stroke care units and stroke surveillance systems, to strengthen the services. And WHO has supported capacity building efforts. Of course, stroke physicians from countries have been received hands-on training through Asia Stroke Summer School last year. And the region is working with academic institutions to develop various manuals for implementing stroke care registries in resource-limited settings, I think, which is very crucial. And also we are supporting countries to implement the WHO Seer Hearts initiative that brings together prevention of CVD risk factors with management of hypertension and diabetes on a single platform to achieve time-bound milestones.
Excellent. I have one more question for you. I know your time is short, but I do want to ask you, I believe that you're a former Minister of Health, as well as currently being Director of Healthier Population and NCD's Department for the World Health Organization in Southeast Asia. What message would you send to stakeholders, including policymakers and program managers, to encourage them to take action on stroke?
Thank you for this question. As I said earlier, stroke remains one of the leading causes of death and disability across the region and globally. And it is critical, and it's a critical health challenge that not only affects individuals, but also has far-reaching economic and social implications. Every stroke is a tragedy, not just for the person who suffers from it, but for their families, communities, and societies. And as policymakers, it is essential that we view stroke not merely as a medical issue, but as a broader public health and economic priority. We have the knowledge, the tools, and the evidence to reduce the burden of stroke through effective prevention, timely treatment, and rehabilitation. However, action is needed at every level of society. It starts with investing in health systems, making stroke care accessible to all, prioritizing public awareness and education on prevention. And some of the key steps could include, improving, of course, prevention, addressing risk factors, such as hypertension, diabetes, unhealthy diets, physical inactivity, which are major contributors to stroke. And we must ensure that prevention programs reach the most vulnerable populations. Strengthening health systems. We must ensure that countries have necessary infrastructure, including trained healthcare professionals, diagnostic tools, and affordable treatment for stroke management, particularly in under-resourced settings. And thirdly, increase in awareness and education. Public awareness campaigns are essential to reduce the stigma surrounding stroke and encourage early detection and treatment. The quicker a stroke victim receives treatment, the better the outcomes, and we all agree with that. And fourthly, promoting rehabilitation and long-term care. Many stroke survivors face long-term challenges. It is vital that rehabilitation and support services are available to help individuals regain independence and improve their quality of life. So by investing in stroke prevention and care, we can save lives, reduce disability, and improve the well-being of millions of people. And I urge policymakers to prioritize stroke as a critical health issue and to make immediate and sustained action. This is an investment in our people's health, productivity, and future prosperity. Thank you.
This is wonderful. Thank you very, very much. And we're going to take that part right there, which with your call to action, and send to as many ministers of health around the globe as we can, because what you've said is so very important. And I know you are extremely busy today, and all of the work you're doing. We appreciate you taking the time to speak with us. Thank you so much. We're going to move now. I want to make sure that I answer some of the questions in the chat, in the quick Q&A section will be postponed until the end of this, but we will get to your questions if we can. One of them is very important, though. Someone asked, will there be a press release about this? There is, in fact, from the Global Stroke Action Coalition, a Stroke Action Now policy brief. The link is in the chat. Laura has posted it there. You can also find the World Health Organization publications related to stroke in a link that is posted there as well. So if there is something that you heard from Hussain, Rasheed, that you really want to know more about, that is a place to go to find out more information. Again, stroke survivors are critical to this effort to fight stroke and to make sure that there is stroke awareness. Melinda is from Norway. She is a stroke survivor and also an associate professor and a medical doctor. She has a story to share with all of you now.
I am Melinda Roaldsen, Associate Professor, Medical Doctor and Stroke Expert, and I live in Norway. I suffered a stroke due to an carotid artery dissection, that is a tear of the main neck artery, when I was 41 years old. I received excellent acute care, thrombolysis within the golden hour, and afterwards I underwent a thrombectomy and got a stent. But right afterwards, when I woke up after the thrombectomy, I could not speak at all. I could not produce even a single sound. I could not walk at all. In fact, I had hemiparesis of my whole right dominant side. I even had swallowing and breathing difficulties. I was in a state of utter despair. But in retrospect, I consider myself lucky, because I was transferred immediately from the stroke unit to an excellent rehabilitation department. And at the very first week there, I set goals. I made several promises to myself. One was that I wanted to hold lectures again at the University of Tromsø, and the other was that I wanted to go snowshoeing again in the Norwegian mountains. And these goals might seem sky high, considering the state I was in, but the fact is that I achieved my goals and fulfilled both promises to myself by the end of February. I got my stroke mid-October. It would not have been possible without my rehabilitation team and without the support and love of family and friends. Health is something close to all our hearts, and considering the fact that 1 in 4 of us will have a stroke, governments must invest more to prevention, for we know that 80% of strokes is preventable. And we must ask ourselves, what is one single human life worth? My personal perspective is that a life is a whole universe of its own, all the people we touch and affect throughout life. We make more impact than we dare to imagine. And we are all part of community, and that is why it does not make sense to save a life without ensuring that we can live the best possible life.
Forgive me for turning my camera off for a minute. For the survivors on this call, you know how this resonates with you. And it certainly resonated with me. Melinda is absolutely inspiring, but remembering the place that she was, the place that we were, it is very moving, and it really causes us to reflect on how far we have come. So Melinda, thank you for your honesty, your bravery, your inspiration, for your lectures, for snowshoeing. I'm now going to learn how to do that. And I think I want to do it in Norway with Melinda. And for, your perseverance to accomplish all of that in 4 months is absolutely remarkable. So thank you for your story. And Joseph, thank you for your story as well. It's not easy to share. It's important to share if you're willing and able, but it's not easy. So I thank you very much for doing that. Katherine is a health policy analyst at the health division of OECD. And I think it's very important to talk about what can be done to improve the health system performance towards stroke prevention and care. That is what she will be speaking about to us now.
Thank you very much, and hello to everyone today. It's a pleasure to be here and participate on this panel and discuss this important topic. And a big thank you to Joseph and Melinda for sharing your remarks. So that was really great to hear. I'm going to discuss 3 main themes today. The first is the heavy burden that stroke puts on lives and health systems. Second is the fact that primary care is an underused tool for stroke prevention. And then third, that stroke care quality and outcomes can vary widely. And so that indicates that there's some room for countries to make gains. The OECD is a benchmarking and really data-focused organization. So I just want to ask for forgiveness in advance because my remarks are going to be a little bit heavy on the quantitative figures. Stroke, of course, remains a leading cause of death and disability across OECD countries. And so that's part of the motivation for the importance of this topic. Cerebrovascular diseases costs the EU, for example, approximately 76 billion annually. And I noticed the global costs cited in the new Stroke Action Now policy brief estimated that the global burden is almost 10 times this figure. And so this really illustrates a heavy economic burden that also reflects human suffering and lost potential. We've seen a lot of progress on a number of risk factors that influence stroke in OECD countries, including risk factors such as tobacco use, alcohol consumption, and air pollution, which have all been trending down. However, there's a number of clinical and intermediate risk factors related to metabolic conditions, high blood pressure, and obesity that have been increasing. Addressing some of these risk factors in primary care through screening and advising on them are key tools for primary care to identify and prevent cardiovascular conditions. Over the last several years, the OECD has been developing a new tool called the PARIS survey. PARIS is an acronym. It stands for Patient-Reported Indicator Survey, and it's the largest global survey of patients receiving primary care. It represents over 100,000 patients across 19 countries and collects a lot of information, both about their health outcomes, but also their experience of care within their health system. And we find that there's a number of areas for room for improvement. So, for example, we see that only about half of healthcare users that report currently smoking also report that a healthcare professional talked to them about the risks of smoking and ways to quit. And less than half of healthcare users had a healthcare professional that talked to them about important issues or risk factors such as physical activity and diet. We know that some of the biggest benefits for reducing stroke can come from targeting people that already are living with cardiovascular conditions. And here we also see that there's significant room for improvement. Around 55% of people with cardiovascular disease or hypertension reported that their primary care doctor gave them advice on physical activity, for example. This is 10 percentage points more than primary care users that don't have cardiovascular conditions or hypertension, but still represents a major gap where improved counseling for the most at-risk patients could benefit. And we see similar deficits in for other counseling subjects, such as healthy eating, alcohol consumption, and smoking. In addition to behavior-related risk factors, comorbidities and clinical risk factors can also be addressed in better primary healthcare delivery. For example, people with metabolic disorders are at particular risk for the development of stroke and often experience worse outcomes and complications following. And we see that prevention activities for patients living with diabetes, for example, could be improved. In data from the OECD Safe Prescribing Practices database shows that in EU countries, around 85% of patients living with diabetes currently receive prescriptions for antihypertensives, and around 70% receive prescriptions for cholesterol-lowering medications, indicating that there's still potential for improving coverage gaps here. Of course, not all risk factors can be avoided, particularly non-modifiable ones. Age, for example, this is particularly important for the OECD. And we see, for example, that the share of people over age 65 in the EU is expected to reach almost 30% by 2050. So this is an increasingly big challenge for a number of OECD countries. In addition, stroke is impacted by gender, and the average cerebrovascular mortality is notably higher in males than females, but this gap ranges depending on the country. And in several European countries, male mortality rates exceed female mortality rates by as much as 30 to 50%. So this suggests that our current prevention activities are probably not adequately tailor-made for certain populations, or that men, for example, may be more exposed to some of risk factors such as smoking, poor diets, and limited health-seeking behaviors, all of which we can better improve health systems to reach these individuals. So while primary care is key, hospital care also needs to remain a critical focus, not only because of its importance in terms of cost control, but also because high-quality care can improve outcomes and reduce disability. We see that hospital discharges for circulatory diseases in general are trending down, but there's still significant variation in country rates that indicate that better performance and reduced admissions can be achieved through better access to high-quality primary care. So one of the examples that was cited several times already is the importance of emergency care, which is a critical part of the care pathway for people experiencing a stroke, and a situation where timely and effective care is really critical. Recent research from the OECD found that cardiovascular diseases account for typically around 6% of hospital emergency department visits. And findings from our Paris survey, the study of people living with chronic health conditions that are primary care users, found that 2 in 5 people with cardiovascular conditions have used the emergency room in the last year, and that these individuals are twice as likely to have gone to the emergency department as those living without CVD. From the OECD side, we're also currently working to capture more national benchmarking indicators that can better provide insights on the timeliness of emergency care. So despite the downward trends across countries, hospitalization still remains a common occurrence for people living with cardiovascular conditions. Similarly, for people with cardiovascular conditions attending primary care, we see that 1 in 4 people with cardiovascular conditions have been hospitalized in the last year, and that these people are more than twice as likely to be hospitalized as people without cardiovascular related conditions. And that the effectiveness of the care that people are receiving varies. And the likelihood of surviving an admission for an acute cardiovascular event can vary depending on where you are geographically. Using OECD data, we see that 30-day mortality following ischemic stroke, for example, can vary as much as 5-fold between the best and the worst performing country. Something that's also been cited a number of times by the other speakers is the importance of effectively coordinating and implementing effective post-acute and rehabilitative care, which is an ongoing challenge for countries. Part of this also has to deal with the data systems to really track how well integrated care and post-acute care is functioning. Through our OECD work to better understand the performance of integrated care, we're able to see that on average, around 20% of people that are discharged following a stroke are readmitted in the year following, and that there's around a 20% mortality in the following year within the same group. We also see that there's significant variation across countries, so there are opportunities for countries to improve their coordination once people leave the hospital to better link them with ongoing primary and rehabilitative care to improve their long-term outcomes. We've heard today from the speakers a number of challenges, and it's clear that stroke prevention and care are a real challenge for countries' health systems and their ability to deliver high-value integrated care. And the costs are high, so that's also a significant motivation. But the fact that there are high-performing countries does show that better outcomes are possible, and that's why I'd like to join my colleagues' calls for better systems to monitor and appropriately prioritize stroke prevention and management in national health systems. So thank you very much again to the organizers for the invitation to participate today, and thank you very much. Over.
Thank you very much. We really appreciate that. I'm sure there will be a lot of questions that you will have coming to you in a few minutes from the people who are attending this discussion. We're going to talk now about the global progress that we've seen with non-communicable diseases, pitfalls, opportunities to collaborate with OECD and other organizations from the Non-Communicable Disease Alliance, from the NCD Alliance. Joanna is joining us now. She's Policy and Advocacy Manager for Care with the NCD Alliance. Joanna.
Thank you very much, and good afternoon from Geneva. Thank you very much for the World Stroke Organization for the opportunity to speak today. I'm here on behalf of the NCD Alliance, as mentioned. We're a global civil society network with over 500 members across 80 countries, including 72 national and regional NCD alliances. It was fantastic also to see that Joseph is here speaking as well from the Rwanda NCD Alliance. We're united in the fight against NCDs. As you know, NCDs are a health tsunami. They are the leading cause of death globally, responsible for 43 million deaths a year, 75% of global mortality. And as already discussed several times today, stroke remains the second leading cause of death globally and a major cause of disability as well as dementia. It is highly preventable and treatable, and like many other NCDs, it's driven by a core set of modifiable risk factors: tobacco and alcohol use, hypertension, diabetes, obesity, high sodium consumption, and physical inactivity. These are the same risk factors at the center of cardiovascular disease, cancer, diabetes, chronic respiratory diseases, and this really kind of underscores the need that integrated prevention and health system responses are needed across all NCDs. And we're dangerously off course. According to the UN Secretary General's report in 2025, only 19 countries and territories are on track to meet the SDG target 3.4 to reduce premature NCD mortality by a third by 2030. And this isn't just a missed milestone, it's really a wake-up call. Despite over a decade of global commitments, progress remains insufficient. The commitments really exist already, and now we need to be delivering on them, and we need to do this together. And this is where the fourth UN high-level meeting on NCDs and mental health is really important. It takes place on the 25th of September in New York, and the theme is on leadership and on equity and integration. It has been 7 years since the last high-level meeting, and this one comes really at a time when ambition must be reset and we need to accelerate action. The geopolitical context is very challenging. Wars, humanitarian crises, climate emergencies, economic instability, and of course, in many countries, politics are not in the corner of public health. The recent US aid cuts have created additional uncertainty, and this is especially the case in low and middle income countries' health systems. Another important issue is that unhealthy commodity industries are all over this process. They're trying to water down outcomes and deflect from public health policies. We know that companies producing ultra-processed foods and sugary products are lobbying actively. High-level meetings matter. They really put NCDs in the spotlight for 12 months before the meeting. We have 6 months left. Crucially, the process is as important as the outcome. It's a chance really to focus attention, renew commitments, and set the new path forward. This year's high-level meeting, we're also assuming we are expecting update global NCD targets. Most of these are expiring in 2025, and these will act as a stepping stone also towards the 2050 health and development agendas. And we need to ensure NCDs, including stroke, have a central place in these processes. Looking at 2025, it's really important that we will harness our collective power and ensure that this high-level meeting delivers real progress across all NCDs. These recent freezes of US foreign aid has also revealed the vulnerability of vertical health programs, but it also creates this space to rebuild more resilient and integrated systems, ones that are better able to prevent, detect, and manage chronic conditions. This is our chance to bridge silos and push for joined-up approaches and to bring together NCDs, infectious diseases, mental health, and maternal health, and really think about things in the people-centered systems that need to actually meet the needs of all communities. For NCD Alliance has set out the clear framework of 5 priorities to unite the civil society. A common voice is really essential to secure meaningful outcomes. It was great to see these priorities launched today, aligning very closely with this framework. Firstly, accelerating implementation. We already know what works. Governments must double down on proven policies and integrate NCD care into primary health care. 2, mobilizing investment. Sustainable financing for NCDs must match the scale of the burden. Domestic and international financing gaps must be closed. 3, breaking down silos. Integrated NCDs with broader health and development agendas, universal health coverage, climate, humanitarian responses, and pandemic preparedness. 4, engaging communities. People living with NCDs must actively be involved in decision-making at all levels. And finally, 5, strengthen accountability. New global NCD targets for 2050 are needed. Along with these, we need regular reviews and strong monitoring mechanisms. 2025 high-level meeting is our chance to regain this lost ground. The stroke community has a vital role to play. We need to amplify the urgency, align with the broader NCD movement, raise the profile of stroke, and join forces on common demands. We must speak with a unified voice, be politically strategic, and make this high-level meeting a turning point. Thank you very much.
Thank you very much, and thank you for those points. I always love when we have a call to action, Joanna, of what we need to be doing, and we will pay attention to that and follow your lead there with the NCD Alliance all over the world. We're now going to talk about United in Action. There is a video that we want to show you to better illustrate the community that is being built and the progress that we intend to make sure will happen. Take a look at the video.
Every 2 seconds, someone somewhere will have a stroke. This year, 7 million people will die as a result.
For those who survive, their lives will be changed forever.
At least half will live with a serious disability.
And 1 in 5 will experience another stroke within 5 years.
Ravaging the brain's connections, stroke isn't just a personal tragedy, it's a global health and economic crisis.
The cost to individuals is immeasurable, but the economic cost is clear and starts at an enormous $890 billion a year.
If we don't act now, by 2050, the stroke death rate will increase by 50%, running up an annual global bill of $1.6 trillion US, a huge burden that will be carried by us all.
But it doesn't have to be this way. This is one global crisis that we have the knowledge, tools, and treatments to tackle.
Stroke is preventable. High blood pressure, smoking, and diabetes are risk factors for stroke, and all can be controlled.
Action to reduce these risk factors alone will reduce the burden of stroke by at least half. Stroke is treatable.
Stroke treatment options such as mechanical thrombectomy and thrombolysis have advanced significantly over the past 3 decades.
and timely access to these treatments can increase the chance of a full recovery.
And yet, globally, only 3% of patients receive thrombectomy treatments that could allow them to live lives free from the effects of stroke.
In low-income countries, patient chances are even worse at just 1 in 100.
Stroke is beatable. Recovery doesn't stop at treatment. Access to rehabilitation in and out of the hospital promotes independence, improves well-being, and reduces the social and economic impact of stroke.
This September, government leaders from around the world will meet at the United Nations to review their progress and agree on actions to advance progress on their Sustainable Development Goal commitments.
By using that meeting to put action on stroke center stage, we know that governments can unlock progress towards health for all.
Every government can do something to improve outcomes for stroke.
To achieve global stroke and development goals, our leaders need to develop national stroke action plans and put stroke at the heart of NCD strategies globally as well as nationally.
They must commit to and invest in prevention, treatment, and rehabilitation.
Ensuring accountability with clear targets and stroke data collection.
And engaging stroke survivors and carers in decision-making every step of the way.
There's no time to waste.
Every minute counts. We need stroke
action now.
Look at all those organizations and companies and individuals involved in this fight that we are all in this mission that we're all in. So inspiring. I love, love, love that video. Many of you have put questions in the Q&A section, and this is the time that we now are going to pose your questions to our panelists. I want to start with one that has come from Cheryl, and Cheryl is writing, when we talk about best practices and policies addressing treatment and care, are there steps to improve assessment and treatment for non-physical stroke symptoms and impact? I'm referring specifically to emotional, personality, and behavioral changes. This is including in rehab for ABI and TBI. And after the death of my husband to suicide post-stroke, I have become a strong advocate in silent stroke education and risk of post-stroke suicide. Are these a focus for reducing the burden? Dr. Pandian, I'm going to start with you.
Yeah, thank you, Sharon. And, it's an important question, and particularly post-stroke care and the neurological effects of stroke, particularly anxiety, depression. They are pretty common. And from World Stroke Organization perspective, we have post-stroke care checklist. We encourage all the centers, physicians, not to neglect this area, because we can identify some of these changes very early if we clearly screen for these conditions. And like for prevention, you screen for risk factors. For post-stroke care problems like this, unless we screen, we won't be able to identify these problems early and treat. And so in terms of treatment, there are treatments available, but it's challenging. And it not only affects the individual, but also the other family members.
Dr. Martins, would you like to weigh in? Can you unmute? Sorry.
Hi.
Perfect.
Sorry. Well, I think it's very important. We think in post-stroke care, and we are working hard on this. Sometimes people forget about the other symptoms and not motor symptoms, but we are working hard to improve rehabilitation and to aware about all aspects after the stroke that are important. And with this, I think we really can improve the stroke care and include these patients in a better life after the stroke.
Excellent, excellent. I have another question for you from Ana Puentes, she's a journalist working on a story here, and she has a question about what place does Africa have in the Global Stroke Action Coalition? There's going to be a special call. Will there be a special call or focus on continents such as Africa, where there have been warnings not only of an underreporting of this disease, but also a need for research, prevention, and rehabilitation?
Yes, we started 2 years ago to work there with Africa as a model, initial model to build the basic stroke care and stroke units in acute stroke services in Ethiopia. After we progressed to Tanzania, and last year we have an evaluation from more countries in Africa as Kenya, Uganda, Zimbabwe, Namibia, Congo, Nigeria, Benin, Guinea, Cameroon, Senegal, to organize services there, to get donation of medication, of thrombolytic drug, to start thrombolysis, but not only this, to organize the whole stroke care that is so important, and also MERS Therapeutics, that is another partner working with us for rehabilitation in Nigeria. And I think about research, Jeyaraj has more to tell about this.
Yeah, I will just, Sharon, I'll just update regarding Africa. Mia Cooper and me, we attended the Global NCD Alliance meeting, and we were able to meet the WHO Afro region, some of the senior officials. So we are planning to work with them, and also individual countries like Rwanda, Madagascar, and recently Seychelles. So we are going to start similar programs like what Sheila had mentioned. Yeah.
Excellent. Joseph, I have to bring you in here to find out what the NCD Alliance has been doing in Rwanda, and also find out a bit about your perspective as a survivor on what more needs to be done there. Can you unmute? Maybe we'll let Joanna start with NCD Alliance and what is being done in Africa, and then Joseph, you can tell your perspective for Rwanda. Joanna?
I think this really belongs to Joseph, but yes, NCD Alliance Forum in Africa, we had over 700 delegates come together, really talk about what happens for the high-level meeting and really uniting that civil society. I hope, Joseph, you can unmute and comment as well, please.
I'm going to come back to Joseph, but Joanna, while you're there, there is a question for you about a suggestion on citizen and population education about NCD prevention and treatment.
Thank you, Sharon. I think the key thing around prevention is also to consider different determinants of health. So social determinants, economic determinants of health, because there is a number of different approaches that governments can take, which are not directly just education, but actually thinking about protecting populations. I'm talking about labeling, health taxes, etc. And I think there's a number of different,
No, go ahead.
There's a number of different initiatives, of course, in terms of different prevention education. But I think it's important not to forget the kind of the environment that people are operating in, and focus on those determinants of health. Thank you.
Excellent, excellent. I am going to get to you, Joseph, at the end, but I wanted to ask this question that Nick Ward has posed to Melinda. Recovery from stroke is a lifelong process, so how do we ensure that rehabilitation treatments are available beyond 3 to 6 months post-stroke? People with stroke currently feel abandoned and unsupported after they get home. I've already expressed my interest in my participation in support groups, Melinda, that really saved me. And this, to me, is a support group of people all over the world, and my new best friend, Melinda from Norway. So what do you think what is being done there? What do you think should happen as a medical professional and a stroke survivor?
I think it is vital that the governments make national stroke action plans for the whole chain of stroke care. That is not only prevention and acute care, it must be rehabilitation and life after stroke. and life quality. I think it is, in fact, we must drive for systematic change all over the globe in all countries to push the national stroke plans all over.
Thank you very much. I appreciate it. There are so many questions, and unfortunately, we are getting close to our end time, so I may not be able to get to all of them. But one that I would like to pose, if possible, to Katherine is, how can we ensure equal access to stroke rehabilitation care and participation in research trials?
Yes, so I think this is something that we still have very little data on internationally for international benchmarking in terms of the availability of rehabilitative beds, for example. We have seen some data from the OECD, but very high level, and it's something that we're looking into how we can get more granular information. So I think this kind of strengthening data infrastructure to be able to get this information and understand which where the gaps remain is essential.
Excellent. I want to get to, before we close out, make sure that you all have bookmarked, taken a screenshot, and seen the slide that's going to come up now. That is the action plan, basically, that are the asks of what we want to happen from this inaugural event that we have just been a part of. The road to the UN high-level meeting, outlining what the coalition's activity priorities leading up to the September 2025 meeting. Number one, make stroke a priority of non-communicable disease health strategies. 2, develop a national stroke action plan. 3, commit to funding stroke action now. 4, implement robust stroke monitoring systems. And 5, include stroke survivors and caregivers in policy development. And I especially thank you for adding that one. The question that has come from Julio actually had a comment, which is, can we share the video? That was so fantastic. The chat is just blowing up with how many wonderful comments about the video. So please include a link in the chat if it is possible to share that. And all of you, of course, please go to LinkedIn to see what the World Stroke Organization is posting about this event. And there will be the video, I'm sure, there as well. But another question that comes from an attendee is, how do we sign up for the New York meeting? And Sheila, can we just sign up? Dr. Martins, Dr. Pandian, can we just sign up, or you're going to represent us there?
Yeah, Jeyaraj will represent us.
Yeah, we'll be representing the coalition, and yeah.
All right, so that means get on LinkedIn and tell him everything you want him to bring up at the meeting. No, limit it to at least 2 comments, or no more than 2 comments. And now I'm going to ask each of the panelists for just one sentence, because we're about to close here. What is one question, or I should say, what is one statement that you would like to make for what you hope will result from this UN high-level meeting? What is one statement? Because Dr. Pandian and all of us are taking notes so that he will have the information to bring to that September meeting. Let me start with you, Dr. Martins. What is one thing you hope will come out of that meeting?
Well, so important ask for the governments to include stroke in the national plans in the United health coverage, universal health coverage to ensure equitable access to everyone.
Excellent. Joseph, what is one thing you want to come out of the high-level meeting? Joseph, can you hear me?
Yes, I do.
What would you like to come out of the high-level meeting at the UN?
We want that the high-level meeting take a firm commitment to reduce the burden. All countries make firm commitment to act to reduce the burden of stroke in their country by having action plans and increasing funding for NCDs and stroke.
Absolutely. And Melinda, what do you hope will come out of the meeting?
That the national plans must encompass the whole chain of stroke care, from prevention to acute stroke to rehabilitation, right up to life after stroke.
Excellent. Joanna?
targets, definitely some targets about what needs to happen and within what time frame. Thanks.
Excellent. And Katherine.
Say appropriate investment and delivery of high quality care across the care continuum, starting with prevention.
Excellent. And Dr. Pandian, thank you so much for having me moderate this discussion. You've gotten all of these notes to take back with you for the UN meeting in September, and what is going to be your major call to them for what needs to happen. I'll let you close out this panel discussion.
Yeah, I think thank you, Sharon, for moderating this great launch event of this Global Stroke Action Coalition. And we had very good discussion points. And I thank all the panelists and also the participants for their comments, questions, and we will definitely summarize all these action points that will be included in the upcoming World Health Assembly, and also few meetings in New York before the September UN General Assembly meeting. And to me, the most important thing is we need to push for a national stroke action plan that will have everything what we have been discussing in this webinar. And thank you very much. And once again, on behalf of the Coalition and World Stroke Organization, we thank you all for joining.
Thank you all.